1 of every 3 babies born in some hospitals in the Bronx are born to mothers who are HIV positive. Over half of the beds in the city hospitals in New York are occupied by individuals who are HIV positive. This is a huge problem in the inner city on the East Coast. It has at this point virtually overwhelmed the clinical care and social support services of many of the larger East Coast cities, is rapidly generating that kind of problem in Southern California, and at this point it may also be overwhelming the research capacities. So we are, although we've been doing a pretty good job up till now, the volume of ill individuals is rapidly outstripping our capacity to take care of them. And yet, we're probably going to be caring for about 5 to 10 times as many patients by the mid-1990s and the late 1990s as we are right now. And this is a combination of the fact that the clinical disease of AIDS takes a while to develop. People are HIV positive, but it takes a while for this virus to do damage and cause clinical illness. In addition, we're getting better at delaying the onset of that late stage of disease when people are clinically ill. So we're doing, 2 things are happening. The disease is running its course and kind of catching up now so that people are coming in with late stage disease, but we're also delaying that, pushing that back a little bit with therapy. So we're going to be having a lot more patients who are coming to us by the mid-1990s. And in spite of the fact that you may have seen some graphs that show that the disease may flatten out by the 1990s, certainly in the clinical care settings, it is not going to flatten out. We are going to be seeing lots more patients. The worldwide problem, I guess, is just even more desperate than that. In Africa, it's estimated that there are over 10 million people with AIDS, and it's unknown how many HIV-positive individuals there are. In some parts of Africa, there are essentially no individuals in villages that are between the age of 15 and 40. They're all dead. And this is leaving millions of orphans who are without now caregivers, and has caused for the first time a reversal in the infant mortality rate in Africa over the last 10 years, and is desperately impacting the social structure. If you think about a society where most of the people who are the productive members of society would be simply wiped away. This is what's happening in much of Africa at this point. It's a major problem. And amidst all of this weight of illness and this social tragedy that's happening, amidst this tide, a little ripple has occurred, which has certainly attracted the media's attention. We were just talking here about that New York Times article. Politicians, lawyers, professional organizations getting on the bandwagon. It's grown and certainly gotten a lot of press recently. And that is the concern that your doctor might have HIV disease and it might give it to you. I guess what I can tell you is that as of March 31st, it's known that about 6,436 healthcare workers are infected with HIV. That amounts to about 171 dentists, and this is not in Oregon. This is across the United States. 703 physicians, about 1,350 nurses, and there are probably another 300 surgeons who are HIV positive, perhaps a total of 1,400 dentists who are HIV positive. And it's estimated that there are about 50,000 healthcare workers who are HIV positive. That's a lot of healthcare workers who are HIV positive, and I would venture that if you're interacting with the healthcare environment or interacting in the healthcare environment for any duration, you will have already come into contact with somebody who's HIV positive who is a healthcare worker. It's just based on the statistics of the numbers. So, could one of your doctors, one of your nurses, one of your healthcare providers actually be HIV positive? Could you have been exposed already? Some of these questions I think I'm going to put on the table here and really try to discuss what what the data is about that and what kind of response we've chosen to take in Oregon. I'd like to describe the emotional environment we're working in, present some scientific data about the transmission of HIV disease, talk a little bit about some of the ethical guidelines that have been presented to physicians about taking care of HIV disease, and how there seems to be a dichotomy of thought about the ethical concerns and the ethics of taking care of sick patients, and yet some of the callousness that I perceive has occurred recently about the situation of what if you get infected with HIV disease. Describe a bit about the laws and regulations concerning HIV in Oregon with regards to healthcare workers, and then tell you what we came up with as far as our recommendations for how to manage this situation. The emotional climate is pretty amazing when you start talking about HIV disease. I mean, it really generates almost every emotion you can think of. And the one thing that's consistent is it's whatever emotion, it's felt strongly. And you get in discussions and people really position themselves with vigor. Fear, I think, is probably the overwhelming emotional motivator. And certainly fear has been generated to a great extent by this disease. I think it's no different than what people have experienced in other epidemics. It's unknown, it's a transmissible agent that generates a lot of fear. And I think that the targets for this fear have shifted a bit. It's kind of fluid. And recently, I think healthcare workers have been targeted as a focus for some of the fear that HIV-positive individuals. It's interesting. We were reflecting here. Doctors are now experiencing some of the heat that gay men experienced 5, 6, 7 years ago. It's interesting to be to be put in that position and to experience what it must have been like and what it still is like to be living with this disease in a personal way. The national outcry has been pretty amazing compared to what really is the actual impact of HIV-infected healthcare workers on the total epidemiology of this disease. And it really has generated some reflex and in some cases somewhat bizarre responses on the part of local, state, federal individuals. And we'll talk a little bit about that in a second, already been alluded to by Jim. Opinion polls, for what they're worth, I guess, do help us understand a bit about what the pulse of the nation is feeling about this. And when asked, should your doctor be legally required to tell you that he's HIV positive prior to doing any kind of treatment? And this was not a question that was asked about procedures, about an invasive procedure, but this was just, should your doctor tell you whether he's HIV positive? 93% of Americans responded with an affirmative answer. They said, you bet, I want to know if my doctor's HIV positive. And what's interesting about that is that it reflects, I think, this concern that there's something that could happen that I want to have control over. I want to be able to make a decision about that interaction. And I don't think it really reflects an understanding on the part of the average citizen about the risk of that, of a bad event happening. But it certainly reflects the fact that Americans certainly want to have information that they can make decisions about. And I think that another interesting statistic is that almost 90% of people feel that every doctor, every healthcare worker should be tested for HIV, routinely, mandatory testing. And it is also interesting that when you ask the same question of healthcare providers, there's more than half of the individuals agree with that. 57% of physicians, when asked should there be mandatory testing, said yes, and 63% of nurses say so. That although that's not that high a percentage, there still is this concern of, we really want to know what's out there. What's interesting about it is that although they don't want to, more than half, or just a little over half, think that all doctors should be tested. 75% say that all all persons going into the hospital ought to be tested. So there's a little bit of a difference in the percentage there. So again, what's good for me is not necessarily what's good for you, and vice versa. So there's, people are not thinking with a context that can be applied across the board, and I think that's been pretty true of HIV disease through the years here. Certainly the reasons for these kinds of reactions are understandable. This is a bad disease. If anybody has had a personal experience with a person who's living with and perhaps has died of HIV disease or AIDS, this is not a good disease. This is a disease which has no cure. We suspect that everyone who is HIV positive will eventually probably succumb of that disease if they don't have some other intercurrent medical problem. It's a disease associated with behaviors that are not widely held as being the norm. IV drug use, certainly homosexuality as a lifestyle has made some significant strides in general acceptance, but is certainly not universally accepted as a lifestyle that should be followed. And I think that there's not just a little bit of distrust on the part of the general population about doctors. When you say to a person, well, doctors are ethical and they're not going to hurt anybody, I think the general response is, yeah, I'm not sure I believe that totally, and so I think there's some skepticism on surrounding the fact that we may not be able to kind of take care of and monitor the practices and the policies of physicians. And I think to some extent there's distrust of the governmental agencies that are trying to work with this also. In fact, I think there's some real problems there. I think that by and large, governmental agencies have not been real clear in setting HIV policy, and I think that some of the examples that have already been presented are clear-cut examples of that. In many cases, the policies that have been set on state and local levels have really been more politically motivated than actually scientifically valid. And oftentimes special interests do prevail over science and rationality. I think the Helms Amendment is a pretty good example of that. And there really is simply no rational justification for that kind of approach to this problem. I think the administration, the Bush administration, is sending mixed signals also, and I think sometimes it's hard to track where they are as far as leadership. I guess the most current example is the difficulty we've had in trying to figure out why the administration still feels that restricting HIV positive persons from immigration is a good policy, when all of the scientific advisors to the administration feel that this is not a good policy. And in fact, Cuba and Red China are alone in the world, are the countries that are keeping HIV positive individuals out. And I'm not sure that President Bush wants to be put in that company, but at least in this policy, he considers it good policy, and I think that sends some mixed signals, I think, to us when we try to figure out where to go with this, and certainly confuses and creates problems in the general public in trying to figure out what is the right thing to do. So how do we make rational policy with all of this? How do we do that with this emotional background, this kind of waffling and lack of leadership? Well, I think it's generally accepted that if you're going to have good public health policy, it probably ought to be based on good scientific principles. I mean, that is maybe, I don't know, everybody would agree with that, but I think that's pretty much universally held. Let me give you a little bit of the data on transmission. This is a blood-borne, blood-transmitted and sexually transmitted disease. And it also being transmitted from mother to child, both through blood at the time of delivery, and also it's been documented that a few breast milk transmissions have occurred. Okay, in the healthcare setting, there are about 6,400 healthcare workers who are known to have AIDS. Only about 20 to 30 of those have actually acquired HIV disease through an occupational exposure. So most of in fact, the vast majority of healthcare workers who are HIV positive are HIV positive through exposure in their personal lives, not through an on-the-job injury. The vast minority have been infected through needle sticks or other injuries. In fact, there have been a lot of press related to an orthopedic surgeon, Lorraine Day. I'm sure you probably have heard and read some of the things that she's written, concerned about orthopedic surgeons who are at risk. That's a tough surgery. They're in there and working with bones and sharp objects, and it's tough. That's a tough surgery. So at a recent meeting, the orthopedic surgeons all lined up, had blood drawn. And at that meeting, they also filled out a form, and the information about their potential risks of exposure were matched with the blood samples. 2 of those orthopedic surgeons were positive. And both of those orthopedic surgeons had personal risk factors. And in fact, both of them had already been tested and were still doing surgery. 106 individuals had personal risk factors and were negative. 106 individuals were either gay or had used IV drugs in the past and were HIV negative. And yet, only half of those doctors had actually gone and, in spite of the knowledge of their risk, had gotten HIV testing. So for half of those doctors, this was the first time that they'd ever had HIV testing. And in fact, when asked why they hadn't done that before, it was because of concern that they would be ostracized by their peers, that they'd lose their practice, that they would be unable to do what they'd been trained to do, and that these individuals had failed to get HIV testing or had chosen not to because of the fear of the consequences of that. They also were afraid that HIV testing of any sort on their medical records would jeopardize their insurance, would make it impossible to get life insurance, would make it difficult to perhaps get health insurance in the future. So there was a lot of fear, the same kind of fear that gay men have been dealing with for all these years. Same kind of fear is now showing up on part of healthcare providers. I don't think that makes it right not to get testing, but I think that's the milieu that we're working with. And in fact, that paranoia is actually panning out. Increasing numbers of HIV positive healthcare workers are being to use a term, outed in the literature or in the press. And in fact, this is becoming a situation. I think the Oregonian talked about an individual who was an individual in LA that was being extorted by a patient. Who the patient was going to tell the press that this doctor was HIV positive and still practicing. And that certainly would have probably damaged that individual's career significantly. If there are so many doctors that are HIV positive, what is the evidence that there is any risk to patients? Well, certainly the most widely publicized situation is the situation of Dr. David Acer, who is a past deceased dentist from Florida, who has apparently managed somehow to infect 5 of his patients in his dental practice. Quite a remarkable event, actually, when you think about the fact that close to 50 other investigations have been done by the CDC looking into patients of doctors who are HIV positive, many of them doing procedures, surgical procedures, other dentists, and have failed to find one other patient who is HIV positive through a healthcare interaction. How did this dentist manage to do what seems to be almost the impossible, which is to infect 5 of his patients with HIV? I think that the answer to that is still a little cloudy, partly because an investigation into the doctor's practices, which was ongoing prior to his death, was halted by his lawyers. So his legal counsel told him not to cooperate, and he passed away before further questioning could be done. But it appears that his practice was not so much that of an HIV-positive individual, but that of an individual who had pretty horrendous infection control practices. Now, it still is a question. I think we have to leave it. The bottom line is we don't know exactly what happened in this individual's practice, but this is a very, very aberrant situation, and one that doesn't really go along with what we have seen and the evidence from other investigations. It would be, I think, a very tragic event if this single episode was used to set policy. It should certainly be used to consider policy, but I think to use this event to create policy to try to prevent this event from happening again, when there's no evidence that it has been repeated anywhere, I think is perhaps a wrong step. What are the real risks to patients? Well, it's been estimated, first of all, how do you define a rare event? How do you figure out that a rare event happens rarely? Well, it's a little difficult to do, frankly. And in fact, the extrapolations of how often a healthcare worker could pass HIV disease to a doctor or a patient is actually very difficult to do. But there have been some estimates. Some people have said that if an HIV-positive doctor performed somewhere between 50,000 and 150,000 operations, one patient may get infected. Now, what that really amounts to is that if all of the surgeons in Oregon were HIV positive, and if they were doing all of the surgery in Oregon for 1 year, one patient would get HIV infected. That's kind of the frequency. That's the same frequency as we have, or approximately the same frequency that we have with regards to HIV transmission with blood transfusions now. And the kind of precautions that are taken now to screen blood has reduced the incidence of HIV transmission in the blood among blood transfusions to approximately 1 in 150,000 units. Now, that's not zero, but it is certainly very, very unlikely. And compared to other risks, i.e., getting smacked up in a car accident going home from the doctor's office, it is a much, much less risk a smaller risk than a lot of other risks are taken. In fact, in that same group of surgeries, there'd probably be well over 200 deaths just associated with surgical and anesthetic complications. So there really is we need to kind of focus on what real risks are and focus our energies on those real risks. I think that in spite of these risks, healthcare workers really are expected to take care of HIV-positive individuals, and they're put in a little interesting bind now where they're saying, you're expected to take care of these patients, but if you get HIV infected on the job, which is much more likely than the reverse happening, we really feel sorry for you, but we're going to say that you can't practice anymore, and by the way, your disability income insurance won't kick in until you get AIDS. It won't kick in when you're HIV positive, and you can't get life insurance, and maybe you will kick your kids out of school too, just for good measure. I think that, this is sort of, it really is an interesting scenario of, on one hand, expectations, on the other hand, kind of an interesting lack of support. Physicians do have an ethical responsibility to take care of HIV positive patients, and in fact, the AMA Ethics Council has clearly stated that when an epidemic prevails, a physician has to continue his labors without regard to the risks to his own health. There is an obligation for physicians to treat patients with communicable disease because physicians have a social contract. We go into this profession with the idea that there is a social contract. It's inappropriate for any healthcare professional to compromise the treatment of any patient, including those with transmissible lethal diseases such as AIDS, on the grounds that such patients represent an unacceptable medical risk to that person. You can't fail to treat because there's a personal risk. And the practice of medicine is a societal trust, and I'm quoting from documents from the AMA and other places, is a societal trust. It carries with it a societal responsibility. If medicine wishes to retain its respected status as a healing profession, we must continue to provide the best care to our patients, regardless of the risk. And I'm willing to accept that. I think that that's absolutely correct. A physician cannot discriminate against any class or category of patients. And in fact, although a physician isn't obligated to treat all patients, all comers, you cannot categorically discriminate against a group or a class of patients. And finally, neither the fear of patients as a source of infection nor inexperience excuses a physician from the responsibility to care. Physicians have a professional responsibility to confront and overcome personal barriers to care. So we have a responsibility to take care of these patients. And on the other hand, we also have a responsibility to know that within the care setting, everything is being done to try to prevent the transmission of disease. And in fact, the changes that have occurred in infection control policies, universal body substance precautions, have made a major difference in the transmission of disease, both from patients to healthcare providers, but more from healthcare providers to patients. This has dramatically decreased some of the nosocomial or hospital-acquired infections that we have been seeing, and in fact has really been a major benefit to the patient, not quite as much to the doctors, but also, and doctors and nurses, but also to them. We have to be reconciled that although we can reduce risk of developing disease from our patients is part of our job. It is something that is inherent in the practice of medicine. What we have to also be confident with is the fact that this is a manageable risk, that you can do things. You can integrate procedures within your practice to reduce that risk. And I think doctors are coming around to this. I mean, I think risk management among physicians is really kind of taken hold, and we can kind of say that, yeah, we can keep ourselves pretty free of this risk. Accidents are going to happen. But by and large, we can minimize that risk. There are some laws, I guess, that also apply to this. So the legal environment is there, but when you really look at the laws and regulations concerning HIV-positive persons interacting in a healthcare setting, there aren't a lot of specific laws related to infected healthcare workers. In general, any physician can't willfully put a patient in jeopardy. I think that's pretty much a bottom line. And must practice within the standards of care of the medical community. And in fact, the Board of Medical Examiners is certainly allowed to relieve the license of an individual who is not practicing adequate infection control. In addition, in Oregon, we have a law that says that if a physician exposes a patient to that physician's blood, that patient must be notified of that event and must be notified promptly. So that's a little bit different. I honestly don't know how many other states have that particular law. And in fact, a physician is bound by standards that have to do with informed consent, in that if a physician is going to is proposing a procedure be done on a patient, that physician must inform the patient of what that procedure is, what are the risks, and what are the benefits, so that an individual can make an informed decision about whether they're going to participate in that procedure. And I think that the crux of this is, what is a reasonable risk? What is a risk that is high enough to be included in an informed consent procedure? And that is where the gray area is. Is any risk a potential? Are we required to give informed consent about something that has nearly zero risk, or is nearly zero risk enough to ask us to inform a patient? And I think that the standard has been, no, you don't have to inform a patient about something that almost never happens. That informed consent really should be focused on those things that are at least seen with some frequency. And yet, this is the area where there's still some fuzziness. You know, it's interesting because I think the legal battleground right now with HIV disease is not so much, is really occurring in civil court. In fact, HIV as a disease has created more lawsuits than any other disease on record already, and that's just in 10 years. It's amazing. So my concern is that some of the policy that we're setting is actually occurring in civil court. Criminal law has also been applied, but it is not. There at this point haven't been a lot of criminal cases that have been tried. I suspect, though, that there will be at some point a criminal case brought against a physician who's HIV positive, who has at least exposed a patient whether or not that has actually resulted in infection. I suspect that will be somewhere, somehow, that will occur. Okay, so that is kind of the legal vacuum, I guess, is what that we're working in. So again, not a lot of policy, not a lot of legal precedents. So in this setting, how do you make policy? Well, we sort of said, well, we've got to do something here. We've got to give some guidelines. We have to create some kind of document that at least can be discussed openly, and create some guidelines for physicians who are HIV positive. The OMA Medical Legal Task Force back in 1988 actually started to consider this and presented its updated recommendations to the OMA House of Delegates in 1991. Any HIV policy really should be, and we went about this with these basic principles in mind, an HIV policy should follow a pathway of voluntarism, because as soon as you go out looking for people, people go underground. And so you've got to make it a voluntary policy. You need to have it based in education. You need to make it possible for people to do behavioral modification. You need to have some informed consent interacting in this. There has to be tight confidentiality, and there has to be a sense of non-discrimination. The policy also really needs to be utilitarian based. I mean, you've got to have a policy that's workable. The policy, the Helms bill basically is unworkable. It simply wouldn't work. So if nothing else, then on the basis of could you do this, it won't work. Okay, what are the goals of this policy? It's got to be rationally based. So basically what we came up with was a policy that says that a physician who is infected with HIV should seek counsel as to whether his medical condition poses a risk to patients. And the infected physician should disclose his or her condition voluntarily to the state public health officer. The reason we said that the state public health officer should be involved is because if it went to their hospital administration or to the Board of Medical Examiners, the confidentiality is jeopardized. Board of Medical Examiners are open documents and can be obtained. The health division has a very strict confidentiality. An evaluation then would be done after authorization by the infected physician, and would be performed in consultation with the infected physician's attending physician and others designated by the health officer. And these others would be knowledgeable in HIV disease. HIV-infected physicians who choose not to undergo this procedure shall refrain from performing invasive procedures. So basically, it was a bit of a carrot and a stick there, I guess. We would want an individual to feel that they could do this and do it confidentially, but say that if you choose not to do this, you better just not practice any kind of invasive procedures. In the event, and then finally, in the event that an HIV-infected physician demonstrates symptoms of cognitive compromise, which is sometimes associated with HIV disease, he or she should be treated like any other distressed or impaired physician, and there are already guidelines on that. Detection of and intervention on behalf of the impaired physician should remain the shared responsibility of the medical profession. Well, in June, this came out earlier, in June the CDC released its recommendations that says that all healthcare personnel should adhere to universal body substance precautions and should be refrained from patient care if that can't be done. HIV or hepatitis B infected healthcare workers should not be restricted from non-exposure prone invasive procedures, saying that there are a category of procedures which are likely or are more likely to produce a transmission of this disease, and that if you are doing non-exposure prone procedures, that you shouldn't be restricted from that. Now, what are exposure prone procedures? Well, the list is coming out November 15th from the CDC, so we're all anxious to see what they're classifying as exposure prone. And healthcare workers who perform exposure prone procedures should know their HIV status, and those who are infected with HIV should not perform those procedures unless they have sought counsel from an expert review panel, similar to what we already talked about, and have been advised by that panel under what circumstances they could practice those exposure-prone procedures. And those circumstances should involve an informed consent to the patient. So there's a little bit of difference in what we came up with and what then the CDC came up with. A little bit more hard line on the part of the CDC. And I think, again, discussion needs to occur as to whether these are appropriate. Mandatory testing of healthcare workers is not recommended by the CDC. And compliance for these recommendations should be increased through education, training, and appropriate confidentiality. Well, I think in summary, you can see that this is a situation where we've got some data, but not a lot of data. We've got a lot of emotion. We've got a long way to go from the standpoint of developing rational policy, but we made a stab at it. And I think the stab actually works pretty well, because whether you knew this or not, this procedure has been in place and has been utilized for 2 years in Oregon. And nearly somewhere between 5 and 10 healthcare workers have already utilized this procedure and have found it to be very supportive. And in fact, the healthcare providers, almost to a person, utilized the procedure in order that they could go back to their respective facilities, say that I've been asked to reduce or change my practice, and have that as validation for initiating at least starting to initiate some disability proceedings. And in fact, if there's been a help, it's been in supporting physicians in disability. Well, I think that we have a long way to go. And I want to close with that. I want to thank the people on the OMA task force: Dave Fleming, Ruth Rabinovich, Genevieve Burke. Jenny Burke is a former president of the OMA, Paul Kaplan, Barry Bell, George Vaness, Tom Cooney, who is the legal counsel to the OMA, Sharon Scott, Chris Stevenson, and Karen Walker, who's now at our institution working with rural health issues, and Mike McCracken. These people have been really an amazing group to work with, and have been a real support to me in trying to put some of this together. And last but certainly not least, I want to thank personally Larry Foster, who has been a tireless worker with the Oregon Health Division and a trusted colleague and a real true friend through the last several years. Thank you to all of you for listening to this, and I'd be glad to take any questions.
Thank you, Dr. Loveless. Our first question will be asked by board member Kathy Oxborough.
You mentioned that there are 10 million cases of AIDS in Africa, and I wondered how other countries have dealt with testing of healthcare workers and disclosure issues around HIV infection, and what, if any, impact does a country's social and cultural norms have on how they respond to it?
Actually, I apologize. Perhaps that was a misinterpretation. There are about 1 million known AIDS cases in Africa. About 10 million HIV positive individuals suspected. So the numbers are those numbers are big. I don't know that we really know what the real numbers are, but other countries have actually tried to take a voluntaristic approach to healthcare providers who are HIV positive. I think in the majority, in most of the world, a healthcare provider is a valuable resource, and whether they're ill or not is encouraged to continue to provide health care. In fact, in Africa, doctors are so rare that they could be very ill and they would still be allowed to practice. It's just such a dearth of health care in Africa. So I think that perhaps it's a little unique in the United States, where we probably have more doctors than we need. I don't know if that's true, but certainly not in HIV disease. That's not true. But I think that to a large extent, most other societies have been encouraging physicians to continue practice. But it does vary. There isn't a real strong consensus, I think, by and large. Restrictive practices and mandatory testing of healthcare workers is not looked at as being a valuable way to go.
Dr. Loveless, yes. Anna McManus, City Club member. I wanted to thank you, first of all, for the work that you do. I know everyone here appreciates the work that you're doing. You very reasonably present the facts, the low risk of transmission from, let's say, a physician to a patient. What actually happened to physicians who felt compelled, let's say previous to 2 years during the procedures you've described, who felt compelled to inform their patients and explain those facts, what was their life experience when they did that?
By and large, I could give you some anecdotes, but I think the majority of individuals who informed their patients of their HIV seropositive status almost universally experienced difficulty continuing their practice because, quotes, the word got out. And by and large, they lost their practice. I guess there was perhaps the first case that got publicized was a case of a pediatrician down in Texas, and I can't remember his name, but it became known in the community that he was HIV positive. He wasn't doing any procedures, but essentially nobody went to his office anymore, and he was taking care of kids and not doing anything that would transmit HIV disease, but lost his practice. He was unable to continue practicing medicine. And so I think that pretty much the consensus has been that once it becomes public knowledge that a person is HIV positive, that pretty much puts an end to that individual's medical career from the standpoint of patient care. Now, certainly, there are a lot of things in medicine that one can do besides see patients. So administrative duties and other work can be done. I think that a lot of the physicians are willing to consider those options, but I think they feel oftentimes that it's not justified based on the data, that they're really not putting a person at risk any more than you sitting in this room with persons who may be HIV positive are at risk for contracting the disease. It really is related to certain invasive procedures, and there are a group of invasive procedures that have a pretty well defined higher risk of having the surgeon cut his or herself and expose the patient to blood.
Just a follow-up question, were those physicians, did they experience ostracism from colleagues?
Absolutely. Absolutely.
Thank you.
In fact, some of the nastiest things that have occurred on the part of one's peers, and that's I guess a bit of a frustrating and sad comment. I guess there is a pretty good example of a resident who became ill, a cardiovascular fellow actually, who developed HIV disease, Dr. Aoun, who has very eloquently documented the fear and the hatred and the discrimination that he experienced on the part of the medical community, and it's there. It's definitely there.
Betsy Johnson, City Club member. If there's mandatory testing for HIV, is there not a risk that people will develop a false sense of security by a negative result? In other words, promoting a casual technique when the negative may just not have converted, or possible exposure to other diseases like hepatitis?
Yes, absolutely, Betty. And I think that's a very important point to make, that if one is going to do mandatory testing, one needs to have that mandatory testing be periodic. And how periodic? Well, I don't know. I mean, every 3 months, every 6 months. It is estimated that a mandatory testing procedure, if it were done in, let's see, I think they looked at this, and I'm blanking. Well, some state did an assessment of what it would cost to do mandatory testing of the healthcare providers. And it came out, and it was a state a little bit larger than Oregon, but it came out to be about $55 million a year. And it's estimated that for that $55 million a year, you would pick up, on the average, about 20 healthcare providers per year. And I just don't think that that's where I would like my representatives to be putting the resources. I mean, it just doesn't make any sense. And so, yes, you'd have to do repeated testing. A negative test does not mean that you're not infected with HIV disease. You could be in that period of early infection and the antibody test is not positive. So,
Thank you.
Exactly right.
Crane, City Club member, and with the program committee. My concern is about insurance. It's well recognized in this country that young men who are not married, such as me at 39 years old, are we have a lot of worries about getting medical insurance. But my question for you, as we look at physicians who have to buy malpractice insurance, I think of doctors such as my own who see a great number of AIDS patients. Are we seeing that in the industry, in the insurance industry, that doctors who treat AIDS patients are paying higher malpractice insurance rates or having more difficulty getting it? The reason for the question is it's patients who pay for those premiums.
Exactly. That's an excellent question. I'm not really sure. Generally, those individuals who are caring for HIV patients are primary care doctors who tend to ride at the lower end of the malpractice insurance scale. And I'm not aware that there has been a differential to date for those individuals who have a high percentage of HIV patients in their practice. But let me tell you a little anecdote. I see probably about 60 to 70% of my practice is related to HIV disease, but I see patients, general infectious disease consultation. And almost invariably, when my name gets on the bill, they ask me about HIV-related serology, regardless of. So I'm tagged. I am an HIV doctor, and it's sort of assumed that anybody who comes to me is coming for that or is being seen for that reason. So the strategy on the part of insurance companies certainly has been to perhaps minimize their risk somewhat by developing those kinds of procedures. But I'm not aware that malpractice insurers are doing that at this point.
Mark Hammer, City Club member. Dr. Loveless, I wonder if you'd comment on the risk of HIV transmission in nursing homes. I'm aware that there has been concern, some would call it even paranoia, among the staff of nursing homes, leading some nursing homes even to take the position that they were apprehensive about accepting AIDS patients. Given that many nursing homes are dominated by patients that are intermediate care or custodial with few, if any, invasive procedures taking place, what would be your assessment of risks for both staff and patients?
That's another excellent question, because we have had some barriers getting patients into long-term care facilities. And in fact, early on, perhaps the explanation was given to us that we don't have adequate infection control procedures. That's sort of like saying we can't meet state guidelines for adequate infection control, and I was kind because I didn't turn any of those people in who said that, because universal body substance precautions is what is adequate for healthcare facilities. So standard precautions are going to be very effective in preventing the transmission of HIV disease within any kind of healthcare setting. And it's not to say that HIV is not going to be transmitted, but it's a manageable risk, and it's manageable in a long-term care facility, and perhaps even more manageable because of the lack of invasive procedures than it is than we experience in the acute care setting, where there are more needles, more sharp objects, and we have more instances of mistakes which could lead to transmission of HIV. So nursing homes, I think, have a need to be open to this kind of long-term care with HIV patients, just as they would any other disease.
Chris Martin, City Club member. Given the fact that you just a few minutes ago mentioned that there certainly are some exposure-prone invasive procedures, if you were on this review panel dealing with one of those physicians, I mean, would you suggest that they stop practicing, or do you think some precautions are enough?
Put me right on the spot there. If I were counseling a physician, I think I would take the line that there are certain exposure-prone procedures that they probably could give up doing. And again, I'm not saying that without knowing the impact that might be for a cardiovascular surgeon. That could be it as far as their procedures. If an obstetrician, if we're talking about an obstetrician, that could be it. So it is not without some trepidation that I say that, but I think that right now, until we get better gloves, until we get better hardware that's going to reduce the risk of tears and punctures and whatever, I guess I would say that that person probably should not be doing exposure-prone procedures. It's going to be, the question is, what are those procedures going, which procedures are going to be defined as exposure-prone? But I think currently I would counsel that person to do those non-exposure-prone procedures.
I'm very sorry that we've run out of time. As we adjourn, let us again thank Dr. Mark Loveless, Director of the HIV program at Oregon Health Sciences University.